So today's presenters, we have a presentation on behavioral counseling from James Werner and Carolyn Ievers-Landis. Our discussants will be Karen, Liz, and Kathleen, and then we have two cases from Kathleen Woods and Austin Fredrickson. Disclosure statements, nothing has changed. And then go ahead, Dr. Werner, whenever you're ready.
Great, thank you, Claire. Good morning. I'm pleased to be co-presenting today with my colleague, Dr. Carolyn Ievers-Landis. We will be talking about two different behavioral counseling methods that are effective in primary care. Next slide. So after today, you should be able to list and describe these two methods, acceptance and commitment therapy and solution-focused therapy, and their effectiveness, and understand some basic strategies to incorporate these methods into primary care behavioral counseling to prevent cardiovascular disease. So Dr. Ievers-Landis, I'll turn it over to you. Go ahead.
Hi, good morning, everybody. I'm so happy to get to do this again. I'm Dr. Carolyn Ievers-Landis, and just to let you know who I am a little bit, I'm a licensed clinical psychologist. I also specialize in pediatric psychologist, and I'm at Rainbow in the Division of Developmental Behavioral Pediatrics and Psychology. My main area is behavioral sleep medicine. So if you have any adolescents or young adults who have insomnia, please send them my way. So what I'm going to be talking about is ACT, acceptance and commitment therapy. And we used it in our program called Pathways Toward Wellness at Rainbow, which is a weight management program, which now has been whittled down a little bit since COVID to me and one of our registered dietitians. But the constructs that I use with the program are so applicable to what you're doing, and I'm so excited to tell you about it and share this with you. So acceptance and commitment therapy is pronounced like the word ACT. It was originally developed by Stephen Hayes, and here is one of the references if you wanted to get a book that talks about it. And ACT is really a form of cognitive and behavioral therapies. It also incorporates mindfulness, some elements of mindfulness. There have been systemic reviews for health, behavior change, and psychological well-being. These are just a couple that I found when I first was asked to do these talks. So ACT has been used successfully for weight management and psychological well-being in patients who are overweight or obese. And I know that's an issue for your patients with diabetes and also for cardiovascular health. So again, this is a review that just came out last year in clinical psychology and psychotherapy, if anybody's interested in looking at that. And also there's a recent review of the efficacy of ACT for patients with type 2 diabetes. So I just pulled that up for you guys because again, this is also from last year so that you can look at it. So even though I use it for my children from 7 all the way up through 18, it's also been found to be very effective with adults with the types of chronic medical conditions you're dealing with. And here's just a screenshot of these two papers that I encourage you to glance at, because I think when you see these elements, you're going to find that you can actually incorporate these into your practice pretty easily. What I think is really the way you think about ACT is that people really get stuck in their minds, kind of mental experiencing. And ACT is a way to get people out of their head and into their lives. So it's very practical, which I like. As a behavioral sleep medicine person, I'm very practical, and ACT is very practical also. So really the objective of ACT is what we call psychological flexibilities. Being aware that you might have difficult inner experiences. There might be thoughts or feelings and memories. I mean, that's normal. We're all going to have those, and we can notice those. And part of cognitive behavioral therapy is really examining those, being really aware of them, and then kind of figuring out, are they accurate or not? How can I change them? Things like that. Or some people that have anxiety might do a lot of work trying to avoid these thoughts or feelings. So ACT is really the opposite of trying to change or eliminate or avoid these things. Instead, ACT is about being present in your life and also thinking about that you're moving toward valued behavior. So what I'm going to share with you, which I love because it is so concrete, it's a matrix as a tool to help patients think about and encourage their psychological flexibility. Okay, here is my kid version, my kid-friendly version of ACT, which we use for when I see children with pathways toward wellness. My son did these, so thank you, Alexander. So these are really, and I'm going to go through the different 4 quadrants, but as you can see, this looks at toward, away. The top part is kind of being in your life, experiencing things. And the bottom part is about your inner and mental experiences. So this is kind of just the way the matrix looks. I also have versions of this that just has words that describe these different quadrants. Okay, next slide. So talking a little bit about value consistent actions. So what I love about values is values cannot be met and they cannot be missed. Okay, you can only do something that's values consistent, you're moving toward a value, or value inconsistent, you're moving away. And all day long, every day, we actually are doing that. We're moving away and toward our values. And once you actually get this in your head, not that I think this all the time, but now it still comes to me quite often. I'm like, oh, I'm moving away from my value. I'm moving toward my value. But the difference is that goals can be very good and important also. And I do use goals with my patients, but when you're thinking about ACT, the problem with goals is they may be reached or not reached. So when your patients are not reaching goals, they may feel negative thoughts and feelings like they might feel ashamed, guilty, inadequate, or just really embarrassed and have the stigma and avoid meeting with you or seeing you because they missed their goal that they set. Okay, so I'm going to be going through the quadrant with you now, and between every slide, we're going to look at, the different quadrants, and I'll remind you where it is. So I always start talking about the bottom right quadrant, that's values. There is a values card sort that you can get from motivational interviewing, which is huge. I don't even know how many, it's like 50 some values. And there's also one for children. So you can even go through some of these with patients or just talk about it. So everyone has different values and you need to be aware of those so that when you're going forward or away, you have to identify first who or what is important to you. And that's the phrase that I use. A value is who or what is important to you. And in the bottom right quadrant, that's just a picture of a boy with his cat because his pet is important to him. So people will say things like family, friends, health, maybe their fitness levels or how active they are. It might be religion, it might be their job, it might be hobbies, there might be their grandchildren. There's so many things that they might put down there. And sometimes I'll have patients write in that quadrant what their values are, and I'll have that it might not just be for the patient, it might be for the spouse or other people relating to the patient. So the upper right quadrant is toward moves. So thinking about moving toward who or what is important to you. For example, you might walk the dog after dinner each night, or you might get together with somebody to do regular physical activity. And following up, my husband and I just joined a rock climbing gym to go rock climbing together at Akron, right outside of Akron U. And we've been trying to do that 2 or 3 days a week. And so we're moving toward our shared value of wanting to be fit together and weight maintenance and all that. The lower left quadrant is negative thoughts and feelings. I told you that you need to be aware of those and think about them. And sometimes I've actually come upon some very powerful ones when I've asked people, what are some negative thoughts and feelings you've had? I've actually had a child that told me he was thinking about harming the principal of his school. So when you ask people these, sometimes you'll come up with something that's very surprising. But so you need to be aware of these and think about it. But in typical thoughts, people will be like, this is hard, I'm too tired, I look stupid exercising. Other people are better, just like me with rock climbing. I am horrible at rock climbing and I'm afraid of heights. So, that could keep me from doing it. So rather than prejudging the experience, you encourage doing it anyway. Okay, go on to the next slide. And the upper left quadrant is away. So what happens is you have these negative internal experiences, and then you might move away. So you're feeling fatigued. So you stay inside and stream shows, you don't go walk. You might be feeling overwhelmed and you might order pizza rather than fixing a healthier dinner. So what you do is, rather than being stuck, despite these unwanted inner experiences, rather than you're noticing them, you're not judging them. So you learn to have a choice about behavior regardless of negative thoughts and feelings. So you might be like, I'm a picky eating veggies is boring, but you might eat them anyway. You might be like, I'm tired, I'm going for a walk anyway. You might be like, I look ridiculous rock climbing because I only get 2 feet off the ground, but you rock climb anyway. So this is kind of the way, just kind of quick, and I know I'm finishing up with my section, but invite patients to practice using the ACT matrix. So you can talk about this upper half is any behavior sensation that can be observed. So seeing, hearing, smelling, tasting, feeling, doing. The lower half is mental or private things, where thoughts, emotions, urges. Then again, you're thinking about going forward, to the right, or left, away. This is something that you could say to them. I'd like to tell you about a tool I share with my patients to support their health behaviors. It's called ACT. And then you tell them it's cognitive behavioral mindfulness. And then you just tell them the quadrants. I just say values, toward moves, negative moves, away moves. I'm kind of talking to them through it. And then you talk to them the purpose. So keeping your values in mind, moving toward who or what is important to you, being aware of negative thoughts and feelings, and being aware of when you're moving away. So choose to move toward more often, toward your values. And these are just some questions. Who or what is important? What gets in the way of moving toward? What are some of the things you do to move away? Just think about that. And what do you do or could you do to move toward more often? And so this is something I just want you to think about. Can you imagine using this and talking about this with your patients? Okay, thanks so much.
Thank you so much, Dr. Ievers-Landis. Now I'd like to talk with you and present solution-focused therapy in primary care. So this is a patient-centered counseling model that's very strength-based, really focusing on patients' competencies and strengths and abilities and resiliency and past successes, rather than focusing a great deal on the problem and kind of, as they say, admiring the problem. Really getting to what strengths does the patient bring to bear and how can we help the patient do more of that? It's been adapted for use in primary care settings. And the reason I'm presenting it today is, although it has been a model that's been around for about 40 years, and it's been adapted for use in primary care, there hasn't been as much adoption as there has been with MI, motivational interviewing, the 5As, SBIRT, and it's very compatible with these models as well. Next slide. So you may be, after today, you may be able to take some of these skills and techniques and integrate them with those other models. So it focuses on what the patient really wants for their future. And it elicits solutions from the patient. No one knows the patient's life better than they do. And so we want to elicit and bring out from the patient things that are working already and how we can help them get more of that. So that's essentially the question. What's working and how can we help you get more of it? So as I mentioned, it's been in practice and development for about 40 years, and there have been more than 150 randomized controlled trials, some big systematic reviews, and it has also been shown to be quite effective for both health-related outcomes and psychosocial outcomes in healthcare settings. The effect size are similar to other evidence-based interventions like cognitive behavioral therapy, motivational interviewing. And one of the nice things about this is that you can do this at a low intensity, which works well in primary care. So you may have a 15-minute visit with a patient, and you can begin using it there, and you can get quite a bit done in a very short amount of time. But with successive visits, you can accomplish even more. Next slide. So it's been used for many different kinds of healthcare problems and issues. If you look at the right column, things that are very relevant, I think, to our ECHO series are adherence to treatment and weight management, improving diet and blood sugar control, physical activity, and so forth. So all of these references will be on slide 46. This presentation will be posted soon on the Cardio website if you're interested in reading more about these specific health problems and solution-focused therapy. Next slide. So some of the key assumptions are that change is occurring all the time. So in any behavioral or biological system, nothing is always static. Changes do happen and exceptions happen. There are times when problems are more severe or less severe. So the questions in solution-focused methods and questions are really the basis of using this technique are framed as when something changes rather than if something changes. So we assume that change is going to happen. Change is also generative in that small changes lead to big changes, or they can lead to big changes. So making small changes is a very, very effective way to help patients begin to make change. Also, we don't need a great deal of information about the problem in order to begin to identify solutions. So don't have to spend a lot of time understanding why a patient is having difficulty taking their medications, what stands in their way, where this problem came from, all those kinds of things. All we need to know is a little bit about it, and then we can help the patient shift towards identifying solutions. Okay, next slide. So these are kind of the key techniques to using solution-focused therapy in primary care. I'm going to go over those that have asterisks next to them today in the interest of time, but they're mostly our questions. So the miracle question, we'll discuss exceptions questions, coping questions. Scaling questions can be used, and they're very similar to MI scaling questions. Like on a scale of 0 to 10, how important is it for you to take your medication or to control your blood sugar or to lose weight, for example? And accolades, simply affirming the patient's strength. So it's similar to affirmations in motivational interviewing. And then we can help the patient come up with very discrete identified tasks and agree upon those tasks, things the patient can undertake between now and the next visit. And these things can be used in any order or combination. So there's an acronym, but it's just simply a way of remembering the skills. Next slide. So first, the miracle question. So with this question, we're really prompting the patient to identify solutions by imagining their own future, a desirable future for themselves. So really kind of looking to the future for solutions from the patient. And the way, there's a couple of ways to ask this. And on this slide, I'll show you kind of the more classic way. And then the next slide, we'll go into a brief way. But you can set the question up by saying, I'd like to ask you a question that's a little bit different than those you might have heard from before in a healthcare encounter or healthcare visit. And it'll require you to do a little bit of pretending. Is that okay? The patient says, okay, or they may ask you a question about that. Okay, let's just imagine that while you're asleep tonight, a miracle happens. And tomorrow, when you wake up, you are on track to getting your blood pressure to consistently stay in the healthy range. What would you be doing differently? Okay. And so that's a beginning question. You may need to, the patient may ask you clarifying questions about the miracle question you asked, which is normal. If that happens, simply clarify the question again. But what would you be doing differently? Well, another way to ask this, if that doesn't lead to productive conversation, is what would other people notice is different that you're doing differently? And then can you walk me through your day tomorrow? Assuming this miracle has occurred, just walk me through your day. Okay, next slide. So a quicker way to ask the question is to just say, let's pretend for a minute that you're on track to keeping your blood sugar in the healthy range. What are you doing differently? Another follow-up question is, what's the smallest thing you would be doing differently if they're not able to identify bigger things that they would be doing? Because small changes can lead to big changes, so that can lead to a solution. Notice that these questions are about doing things differently. So they're very action focused, and because of this, they can lead to actions the patient can take. For responses that are focused on feelings, for example, if the patient says, well, if I was on track, I'd be feeling much better about my blood sugar control and a lot of things. And so you can shift that into the action realm by simply saying, when you're feeling that way, what will you be doing differently? Okay, next slide. Another way to identify solutions in the patient's life or help them identify them is to look to the present and to the past as well to uncover their strengths and successes. So again, this assumes there are always times when a problem is less intense or sometimes even absent. So a way to ask this question is, think about the days when you take your blood pressure medication. What do you suppose is different about those days? Okay, so we're asking them to think about the present or the recent past when they've been taking their blood pressure medication. What's different about those days? Next slide. So next are coping questions. So coping questions are really effective for patients who are feeling a bit overwhelmed. So you can use these questions even when you're not helping a patient work toward a solution for a chronic health condition, but just when a patient is simply in your exam room and they're feeling overwhelmed. But it can also be very effective for helping patients identify solutions. It is a special case of exploring for exceptions, essentially. So next slide. So some coping questions might be, well, that sounds nearly overwhelming. How are you able to manage? So essentially what we're doing is we're expressing empathy, but we're shifting to basically, what are their strengths? You obviously have strengths. You're managing the situation to some extent. How are you able to do that? Or with all you have going on, how were you able to make it here this morning? So we're giving them credit even for the smallest things. Or how are you preventing things from getting worse? So we are looking for even just the smallest foothold to help a patient really come to terms with their own strengths and appreciate their own strengths. One of the things we find in our weight management clinic is patients will come in not having lost any weight since we saw them the last time. They feel defeated and kind of embarrassed. And so, one approach is that we use is to say, not gaining weight is a victory too. How did you make that happen? Excuse me. Because not gaining weight, the things that you were doing there are probably the same things you would need to do, perhaps to a little larger extent or more consistently, to lose weight. So those solutions may be things you are already doing, but we just need to identify them and help you do them more often or to a greater extent, or whatever it may be that's different to help you get to that weight loss goal. But recognizing and putting them on a very positive frame that they have been making good progress by simply not gaining weight since the last visit. And that is very helpful information. Next slide. So you can come back then to tasks, which are, these are basically implementing solutions that the patient has identified that can move them in the direction of their goals. For patients who are ready to take action, they can undertake tasks that are based on action, doing tasks, to bring about these exceptions, these times when the problem was less severe or even absent, the days when they were taking their medication. What do you suppose was different about those days? what those differences are. How can they bring about more of those differences? Or the miracle question of what they're doing differently when they are on track. And it could be even just small parts of their day that they were doing things differently. For patients who are not ready to take action, you can encourage them to just observe or notice when these exceptions happen, when they're taking their medication. For example, what is different about that? Have they gotten up earlier? Did they go to bed earlier so they could get up earlier and organize their day? What was a little bit different there? And these tasks can be suggested by either the provider or the patient. However, the solutions come from the patient. So the tasks are based on patient-based solutions that have been identified. Next slide. So these are just some examples of some action tasks. Would you be willing to try something interesting between now and the time I see you again, just to kind of intrigue the patient a little bit? Or would you be interested in trying a little experiment? And a couple examples. Based on what you were talking about earlier about using alerts on your phone to remind you of appointments like today's appointment with me, what do you think about setting a daily phone alert to remind you to take your blood pressure medication? It would be really interesting to see if the alerts increase how often you take the meds over the course of a week and how that affects your blood sugar or blood pressure, excuse me. Or what would help you move a little closer to your goal of keeping your blood pressure in the healthy range? What's one small thing you might do? So that alone could be a solution-focused question if your time is really limited and you don't have time to use the miracle question or the exceptions question. But it's usually more productive if you've been able to use one of those techniques to help the patient identify solutions. But this is another very encapsulated approach for solution-focused brief therapy. Next slide. So this can have some positive effects on clinicians as well. It's because it removes the burden, if clinicians feel that burden, for finding effective solutions for patients. Really, you're just simply guiding or facilitating, and the solutions naturally come from the patient. They know their lives. They know the context of their lives, their living situations, their personality, who they are, their preferences. So we're just simply drawing these out from them. And this can create a real empowering atmosphere during the encounter by focusing on strengths and perhaps protect clinicians against burnout. Next slide. If you'd like to read more about this, this is a free article available online, a journal article that is quite, I think, effective in walking you through the acronym steps and exactly how to implement solution-focused therapy in primary care. Next slide. Here are some more learning resources and training courses. Next slide. These are the references to the slide that had all the different health conditions for which solution-focused therapy has been used. Thank you all today. Turn it back over to you, Claire.
Sure. So just very quickly, you should have the survey in your inbox to give feedback on today's presentation. And then the last bullet in here is wrong. We need one case for next week. So we have 3 weeks left. We need one case for next week, and then we need cases for our last week. Anyone is interested in presenting, please let me know. Otherwise, we will see everyone next week. Thank you.